welcome to a new deep dive. Think of this as your urgent health bulletin. Today we're tackling a really fascinating and incredibly rare medical case. It's just published in the International Journal of Emergency Medicine, actually, dated July 15th, 2025. Our mission: to unpack a very surprising complication, something quite rare that's been linked to a COVID infection. You're going to find out how a condition that seems, well, relatively straightforward can actually take a really unexpected turn. It can mimic something much more serious. And we'll see why getting the diagnosis right is just absolutely critical. Let's jump in.
Okay, so to start us off, let's unpack this a bit. What exactly are we talking about with ischemic bowel disease, specifically ischemic colitis?
Right. So at its core, ischemic colitis is a condition where part of your colon, the large intestine, isn't getting enough blood flow. Imagine a section of your gut just not getting the oxygen it needs. That lack of oxygen then causes injury, inflammation, damage.
Okay, got it. And what does that look like? Clinically, what are the typical signs? Well, often it presents as a kind of triad of symptoms. You've got abdominal pain, often quite sudden. Then there's bloody stool, and sometimes diarrhea as well. And if doctors do an endoscopy looking inside the colon, they might see things like swelling, that's mucosal edema, or erosions, maybe ulcerations, even little bleeding nodules.
So what usually leads to this? What are the kind of established risk factors, the usual suspects?
Historically, yeah, we know the main risks. Things like coronary artery disease, high blood pressure, chronic kidney disease, and diabetes. Those are major contributors. Actually, atherosclerotic vascular disease, hardening of the arteries, and end-stage kidney disease, those are considered the highest risks. And it's not that uncommon in the grand scheme of things. Ischemic colitis is actually the third most frequent cause of lower GI bleeding.
Right. So established risks.
Right.
But here's where our deep dive gets particularly relevant today. The sources, especially this new case report, point to COVID-19 emerging as a new risk factor. That connection is fascinating.
It absolutely is. And recent studies, including this one, they do confirm COVID-19 as a risk factor for ischemic bowel disease. If you connect the dots, you see that colonic ischemia can happen in patients who've had COVID. And the reason seems to be systemic hypercoagulability.
Hypercoagulability, meaning the blood gets stickier, more prone to clotting.
Exactly. The COVID infection can trigger a state where blood clots form more easily throughout the body, and those clots, or just the general sludginess, can impede blood flow to the colon.
Wow. Okay, so a virus leading potentially to bowel issues through blood clotting. That's a key link. Now, within ischemic colitis itself, the sources talk about a really rare and frankly challenging form, the mass-forming variant, MFIC. What makes this specific type so difficult? Why is it such a medical imposter?
That's a really important question. Because in these rare cases, the ischemic colitis doesn't just cause inflammation or ulcers, it can actually cause the damaged tissue to swell and clump together. It forms these lesions that look remarkably like malignant tumors, like colorectal cancer. That's why we call it mass-forming ischemic colitis, or MFIC.
It looks like a tumor, but isn't.
Precisely. And that visual mimicry is the crux of the problem. It makes diagnosis incredibly difficult. It's so crucial for pathologists, the ones looking at tissue samples, and gastroenterologists doing the scopes, to be aware this variant exists. You know, telling the difference between MFIC and actual colorectal cancer is vital. It helps avoid misdiagnosis and, importantly, prevents patients from undergoing unnecessary major surgery.
Okay, this really highlights the diagnostic challenge. Let's make this concrete. Tell us about the specific case from the journal article. This 72-year-old female patient, her story seems quite extraordinary.
It really is. So this patient, 72 years old, she had some background history. Hypertension, a stent placed for coronary artery disease, and prior surgery for an arterial hemangioma. But the key factor here, she contracted COVID-19 just 2 weeks before her first hospital admission for these bowel symptoms.
2 weeks post-COVID. Okay, and what happened during that first admission?
Right, so first time around, she presented with lower abdominal pain and bloody stools. Classic symptoms, potentially. They did a colonoscopy, and it showed a large ulcer in her sigmoid colon, that's a lower part of the large intestine. It was pretty big, about 6 by 3 centimeters. Crucially, they took biopsies. Pathology came back showing chronic inflammation and inflammatory necrosis, so tissue death due to inflammation and lack of blood flow, not cancer.
Okay, so inflammation confirmed. What treatment did she get, and did it work?
Yes, she received treatment. They stopped her aspirin temporarily, likely due to the bleeding, and gave her an antibiotic, moxifloxacin. And her condition improved quite significantly. A follow-up colonoscopy 3 months later actually showed her colon was back to normal, healed.
A good outcome initially, but As often happens in these deep dives, the story didn't quite end there, did it?
No, it didn't. That's right. 8 months after that first episode, she was back in the hospital. Same symptoms again, lower abdominal pain, bloody stools.
Oh, dear. So they did another colonoscopy.
They did, and this time, the scope showed something different. It showed a mass, about 2 by 1.5 centimeters, located in the sigmoid colon, right where the original ulcer had been.
A mass. After the first episode resolved,
Yeah.
that must have set off alarm bells. Cancer would be the immediate thought, surely.
Absolutely. Highly suspicious for malignancy at that point. But here's where the case takes a truly unique, almost bizarre turn. The very next day after that colonoscopy found the mass. The mass was spontaneously discharged from her anus.
It just can't.
It expelled itself, yes. So they quickly did another colonoscopy, a re-examination, and it showed a large, raw, ulcerated surface where the mass had been just the day before. They managed to examine the expelled mass itself, and pathology again confirmed. Inflammatory, exudate, and necrosis. It was essentially a clump of inflamed dead tissue, not a tumor.
That is unbelievable. So the mass was this intense inflammatory reaction, likely related to the ischemia, and it just sloughed off.
Exactly. The thinking is that severe submucosal edema swelling within the colon wall and bleeding can cause this kind of tissue clumping, forming a pseudomass that can apparently detach and be expelled.
It really hammers home how tricky this MFIC can be. Both episodes could easily have been mistaken for cancer.
Without a doubt, especially that second episode with the visible mass. It highlights why careful diagnosis is paramount.
So given this mimicry, what tools were most critical in getting to the bottom of it? How did they figure out it wasn't cancer?
Well, blood tests, serological tests like white blood cell count, hemoglobin D dimer, which relates to clotting. They're useful for assessing how severe things are, maybe pointing towards inflammation or clotting issues, but they don't diagnose ischemic bowel disease itself.
Okay, so blood tests give clues, but aren't definitive. What about imaging?
CT scans are really the primary non-invasive tool here, and a specific type, computed tomography angiography, or CTA, is particularly good. CTA looks directly at the blood vessels. It's great for seeing the extent and severity of colon ischemia, especially when it's not caused by a complete blockage. It has a very high positive predictive value, around 98%. And in this patient, her CT scans showed vascular findings consistent with what's reported in studies of ischemic colitis.
So CT points strongly in the right direction. But what nails the diagnosis?
The colonoscopy is critical, not just for seeing the ulcer or the mass, but because it allows doctors to take biopsies, tissue samples. Pathology examining that tissue under a microscope was absolutely key in both of this patient's episodes. It was the definitive proof that this was benign inflammation and necrosis, not malignancy. That's what prevented unnecessary surgery.
It really highlights the power of the biopsy. So once you do diagnose ischemic colitis, even this rare mass-forming type, what's the usual approach? How do you treat it, and what's the general outlook?
The encouraging thing is that ischemic colitis in many cases is actually self-limiting.
Meaning it can get better on its own.
Yes, it can often resolve spontaneously without needing highly specific or aggressive treatment. So conservative management is usually the first line. This means things like intravenous fluids to rest the bowel and maintain hydration, nutritional support if needed, and sometimes antibiotics, especially if there is concern about bacterial translocation or infection in the damaged tissue. For most patients, this conservative approach works well and the prognosis is generally good.
What about patients like the one in the case study, with underlying heart issues?
That's a good point. In patients with underlying cardiovascular disease, doctors might consider antiplatelet therapy, like aspirin. But it's a balancing act. You have to weigh the benefit of reducing the risk of clots and further cardiovascular events against the risk of increased bleeding, especially from the damaged colon. In this particular patient, her symptoms improved significantly with anti-inflammatory treatment and, presumably, careful management of her antiplatelet therapy. And the report notes she had no relapse for over a year after the second episode.
That's great to hear. So let's pull back from what are the big takeaways here? Why is understanding this rare case important for you, our listener, wanting to stay informed?
I think this deep dive really shows how interconnected things can be in medicine. How something like a common viral infection, COVID-19 in this instance, can unexpectedly contribute to a much rarer and potentially confusing condition like mass-forming ischemic colitis.
It definitely broadens the picture of post-COVID effects.
It does, and it really underscores, I think, the absolute necessity of a multi-pronged diagnostic approach. You can't rely on just one thing. It takes combining the clinical picture, the symptoms, with advanced imaging like CT, and critically getting that tissue diagnosis through colonoscopy and biopsy. That careful combination is what allows doctors to distinguish these benign, often self-limiting inflammatory conditions from serious malignancies. And that distinction is vital to avoid unnecessary, potentially harmful invasive procedures like major surgery.
It's a powerful reminder, isn't it? That even familiar diseases can present in really varied, sometimes quite misleading ways. Careful investigation is key. Well, this exploration into a really unusual case of ischemic colitis after COVID certainly highlights the body's complexity and how crucial that detailed diagnostic process is. We really hope this deep dive has given you a useful shortcut to understanding a fascinating, though rare, intersection of infectious disease and gut health. And here's something for you to mull over. As we learn more about pathogens like COVID-19 and their sometimes surprising downstream effects, how might a greater awareness among doctors of these rare or atypical disease presentations change diagnostic strategies and ultimately improve patient care in the future?